Welcome back to the Deep Dive. Today we're tackling something really central to medicine, actually. It's this whole complex calculation. How do doctors, how do health systems decide if, doing something preventive, a test, a screening, even a medication is actually worth it for someone who feels perfectly fine?
That's exactly the core challenge, isn't it? Because preventive medicine is fundamentally different. You're intervening on people who are, well, healthy, asymptomatic. And as Harrison's text lays out really clearly, that means the bar for evidence has to be incredibly high, exceptionally high.
Right. You're not treating sickness. You're potentially introducing risk or cost to someone who feels well.
Precisely. We have to be really sure about the effectiveness, sure about the safety, and increasingly sure about the cost efficiency before we roll something out to potentially millions of people. It's a very nuanced decision process.
So that's our focus today. We're going deep into the principles Harrison's outlines for this process, how we get from, hey, maybe this test works, to actually recommending it widely. It really comes down to this critical step, weighing the benefits and harms.
And that weighing process, as we'll see, involves some pretty complex, sometimes uncomfortable calculations.
Okay, let's jump right into that. The financial side, and maybe the ethical side too. Because when you talk about doing prevention on a big scale like nationally, cost immediately becomes a huge factor.
Yeah.
We know the price tag on the test itself is just, well, the tip of the iceberg. So when we're trying to figure out the real economic burden of a screening program, what else are we adding up?
Oh, it's much, much broader than just the cost of the mammogram machine or the lab test fee. You start with the direct costs, naturally. That's the test itself, the equipment, the staff time to administer it, read it, interpret it, all that.
Okay, standard stuff. But then there are the indirect costs, right?
Yep.
The ones that aren't on the hospital bill.
Absolutely. And these can be huge. Think about it from the patient's perspective, time off work.
Yeah. For the screening appointment itself.
Exactly. That's lost productivity. For the individual, sure, but multiply that by millions of people taking half a day off. That's a significant economic impact for the whole country. It has to be part of the equation.
So it's not just medical costs, it's societal economic disruption we're factoring in. But I suspect the really explosive costs come from, well, when things don't go perfectly smoothly with the test.
That's where the downstream costs really kick in, and they can dwarf the initial expense. The big driver here is often the false positive.
Meaning the test says you have something, but you actually don't.
Correct. So a healthy person gets a positive screening result. What happens next? More tests, often more expensive tests, maybe more invasive tests.
Like biopsies, specialist visits, more imaging.
All of the above. And remember, this is all happening to someone who was and still is perfectly healthy. They're undergoing procedures, experiencing anxiety, maybe even physical discomfort or risk from the follow-up. And it all started with an inaccurate screening result. That cost balloons incredibly quickly.
And that ties into another issue. Harrison's mentions these unexpected findings, right? Incidentalomas. That sounds like a made-up word, but it's a real thing.
It is very real and a huge headache, clinically and financially. It means finding something you weren't even looking for.
How does that happen?
Okay, imagine you're doing a low-dose CT scan to screen a long-term smoker for lung cancer. That's the target. But the scan happens to catch a tiny little spot on their kidney, or maybe the adrenal gland, something completely unrelated.
Okay, so what's the problem if it's unrelated?
The problem is, what is it? The chance that this tiny random spot is a dangerous cancer is usually very, very low, especially if the patient has no symptoms related to it. But we can't just ignore it. Ethically, legally, clinically, you have to figure it out.
So that triggers a whole new cascade of tests.
Exactly. Now, the patient needs maybe a dedicated kidney CT, perhaps an MRI, maybe even a PET scan, referrals to specialists, all to chase down this incidental finding that, statistically speaking, is almost certainly benign.
Thousands of dollars, tons of anxiety, potential complications from those tests.
Yeah.
All from the original screening test finding something unexpected.
Precisely. It's a massive hidden cost driver of screening programs. It fundamentally changes that whole benefit versus harm calculation we talked about.
Wow. Okay, so given all this complexity, direct costs, indirect costs, false positives, incidentalomas, how does medicine actually try to put a number on whether it's worth it? This leads us to cost-effectiveness analysis, right?
Yes, exactly. We need a standardized way to compare different strategies.
Yeah.
Cost-effectiveness analysis tries to quantify the value you get for the money we spend. Traditionally, people looked at just the cost per year of life saved. Simple enough.
But simple isn't always accurate, I guess.
Not really, because just living longer isn't the only goal, right? What if those extra years are spent in constant pain or with severe disability from, say, a stroke that was prevented but the treatment had side effects? The quality of that extra life matters immensely.
Okay, so we need to adjust for quality, which brings us to this really key metric that Harrison's highlights.
Yeah.
The Quality Adjusted Life Year, or QES. Can you break down what a QAL actually is?
Sure. A QAA is the attempt to combine both the quantity, the length of life gained, and the quality of that life into a single number. Think of it like this. 1 QALY equals 1 year lived in perfect health. That's the benchmark.
Okay.
Now, if a person lives a year, but they have a condition that significantly impacts their quality of life, maybe chronic pain, maybe limited mobility that year might be valued as, say, zero point 0.5 QALYs or 0.7 QALYs, somewhere less than 1.
So an intervention might give someone 5 extra years of life.
Right. If those 5 years are in perfect health, that's 5 QALYs gained. Fantastic. But if the intervention, while life-saving, maybe causes some long-term side effects, and those 5 years are lived at, let's say, a quality level of 0.6, then the actual gain is only 3 QALYs, 5 years, 0.6 quality.
Ah, I see. So that lets you compare apples and oranges a bit better, like preventing a disabling stroke versus preventing a quick heart attack death.
Exactly. It gives health systems a common currency to measure the value generated by different interventions, accounting for both how long and how well people live.
It's essential for allocating resources, definitely. But Harrison's mentions these cost thresholds, specific dollar amounts per QALY. What are those typically, and isn't putting a price on a QALY, well, ethically tricky?
It is ethically tricky and very controversial. The text mentions, and this is generally accepted in the U.S., that interventions costing somewhere between $50,000 and $100,000 per QALY gained are often considered cost-effective.
$50,000 to $100,000 per quality adjusted life year. That feels like putting a price tag on life, doesn't it? If something costs $101,000 per QLY, we just say, nope, too expensive.
That's the uncomfortable reality of finite resources. It's less about valuing an individual life at that number and more about making pragmatic decisions at a population level. Think of it this way. Policymakers have a limited budget. If they can spend $100,000 and get 4 QALYs with Program A at 25 QALY, or only 1 QALY with Program B at 100 QALY,
They'll choose Program A to maximize the overall health benefit for society.
exactly. It forces the system to prioritize efficiency, to get the most health gain for the dollar spent, allowing them to help more people overall. It's a tool for resource allocation, not really an individual bedside decision, but it drives which preventive strategies get widely adopted and funded.
It's a tough calculation, but necessary, I suppose, when resources aren't infinite. So we have these metrics like the QLY threshold. Who actually does the hard work of sifting through all the research, applying these economic analyses, and deciding what gets recommended? And, importantly, what do they do when the evidence is messy, or when the cost effectiveness is right on that borderline?
The main player in the U.S. for this is the U.S. Preventive Services Task Force, or USPSTF.
Okay, the USPSTF, what are they exactly?
They're an independent panel. Really important that they're independent, not part of a government agency pushing a specific agenda. They're volunteer experts in prevention and evidence-based medicine. Their whole job is to systematically review the evidence for clinical preventive services, screening tests, counseling, preventive medications, and issue recommendations based purely on the strength of the evidence about the balance of benefits and harms.
They're kind of the official arbiters of evidence for prevention.
You could say that. They translate the mountain of research into practical advice for clinicians.
And they use a grading system, right? Not just yes or no. I think it's A, D, C, D, and I. How do those grades tie back to that high bar of evidence we talked about?
That grading system is crucial because it directly influences clinical practice and, critically, insurance coverage under the Affordable Care Act. So an A or B grade means the USPSTF found good evidence, high certainty for A, moderate for B, that the service provides a substantial net benefit. Basically, do this. These are usually covered by insurance without cost sharing.
Okay, A and B are strong recommendations. What about C?
C is where it gets nuanced. It means there's likely some net benefit, but it's probably small, or the evidence is less certain. The recommendation is usually to offer or provide the service selectively, based on professional judgment and patient preferences. This is often where those borderline cost-effectiveness numbers or marginal harms come into play.
So a discussion is needed. And D?
D means the USPSTF recommends against the service. They've concluded there's moderate or high certainty that it has no net benefit, or that the harms actually outweigh the benefits. don't do this routinely.
And then I must mean,
I stands for insufficient evidence. It means the research is lacking, of poor quality, or conflicting. They simply can't determine the balance of benefits and harms. It's not a recommendation for or against, it's a call for more research.
got it. So looking at the recommendations, are there areas where pretty much everyone agrees, where the evidence is just rock solid, leading to those A or B grades consistently?
Yes, definitely. High consensus usually happens when you have a common serious disease and a really good, safe, and effective screening test or intervention. The classic examples where basically all major groups, including the USPSTF, are aligned are screening for hyperlipidemia, that's high cholesterol, and screening for colorectal cancer. The evidence showing benefit, like lives saved and QALYs gained, is strong, consistent, and well within those cost-effectiveness thresholds.
Makes sense.
Yeah.
But Harrison's points out that this harmony breaks down pretty quickly in other areas. Where do we see the most persistent controversy and disagreement, often leading to those C grades or differing recommendations between groups?
The controversies almost always pop up where that benefit versus harm balance is really tricky to calculate, usually because of a significant risk of something called overdiagnosis, especially in average risk people.
Overdiagnosis again, finding things that wouldn't have caused problems.
Exactly. And the two poster children for this, the debates that have raged for years, are breast cancer screening, specifically for women in their 40s, and prostate cancer screening using the PSA test.
Okay, let's dig into breast cancer screening for women 40 to 49. Why is that age group so contentious? What changes the math?
Several things converge for that group. First, statistically, the baseline risk of developing aggressive breast cancer is just lower than it is for women 50 and older. Fewer dangerous cancers to find.
Okay, lower incidence.
Second, younger women often have denser breast tissue. This makes mammograms technically harder to interpret accurately, which increases the chance of a false positive seeing something suspicious that turns out to be nothing.
More callbacks, more anxiety, more biopsies.
Exactly. And then comes the big one. Overdiagnosis. Because screening finds all sorts of things that look like cancer under a microscope. Some are aggressive, yes, but some are incredibly slow-growing or might never progress to cause symptoms in a woman's lifetime. Harrison's actually cites estimates suggesting that maybe 15, even up to 40% of breast cancers found by screening mammography could represent overdiagnosis.
Wait, 40%? Up to 2 out of every 5 cancers found might never have been a threat? That's huge.
It is staggering, and it means you might be subjecting women to surgery, radiation, chemotherapy, years of follow-up and anxiety for a cancer that would never have harmed them if it had been left alone.
That completely shifts the harm side of the equation.
It really does. The potential benefit of finding an aggressive cancer early is weighed against the very real harm of overtreating potentially insignificant ones. That's why the USPSTF often lands on a C grade for this group, recommends selective, individualized decision-making, while other groups might lean towards a B, perhaps prioritizing finding every possible cancer slightly more.
It highlights a difference in philosophy almost.
Very much so. And we see the exact same dynamic with prostate cancer screening and the PSA blood test. Harrison's calls it the prostate paradox.
Right, because prostate cancer is often very slow-growing too.
Extremely slow-growing in many cases. The text notes that many men, especially older men, will die with prostate cancer, but not from it. It just never progresses enough to cause problems before something else, like heart disease, comes along. The estimates for overdiagnosis in prostate cancer found via PSA testing are also really high. Harrison's mentions figures like 15 to 37%.
Similar range to breast cancer.
Yes. And the challenge is the PSA test is good at finding cancer, but it's not good at telling you up front which ones are the aggressive tigers that need treatment and which are the slow-growing pussycats that could just be monitored.
And the treatments themselves have significant downsides.
Major downsides. Surgery or radiation for prostate cancer carries very real risks of long-term incontinence and erectile dysfunction. These massively impact quality of life. So you have this dilemma. Treat potentially insignificant cancers and risk definite immediate harm to quality of life, or watch and wait, risking that a potentially aggressive cancer might progress. That uncertainty, that high risk of overdiagnosis and treatment harm, is why PSA screening generally gets a C or D recommendation for average risk men, pushing it firmly into shared decision-making.
So when Harrison mentions that different organizations sometimes have conflicting guidelines, it's not usually because they're reading different studies, is it? It's more about how they weigh these uncertain harms.
That's often the heart of it. Sometimes it's just timing one guideline is older and missed a key trial. But frequently, especially in these controversial areas, it reflects a different interpretation of the evidence or a different value judgment on that benefit-harm trade-off. One group might tolerate more overdiagnosis to catch every possible dangerous cancer, while another, like the USPSTF, puts a heavier weight on preventing the harms of unnecessary treatment and anxiety in the larger population of healthy people.
Okay, so if screening everyone, or even large average risk groups, is often problematic because of low benefit or high harm, how do we make prevention more efficient? This brings us to risk stratification, right? Finding ways to pick out the people who are truly at high risk, where the test is clearly beneficial.
Exactly. Risk stratification is absolutely fundamental to making preventive medicine work effectively and efficiently. Screening everybody for everything is just not feasible. It's too costly, and as we've seen, it generates too many false positives and harms in low-risk populations.
You want to focus the resources where they'll do the most good.
Precisely. The goal is to increase the pre-test probability, the likelihood that the person you're screening actually has the disease. By concentrating on individuals with known risk factors, you improve the yield of the screening test, making the benefits more likely to outweigh the harms and the costs.
Age is probably the most common risk factor used, right? Things get riskier as we get older.
Age is definitely a huge one. But the USPSTF and other guideline bodies go much further, incorporating specific lifestyle factors, family history, and other medical conditions to define these higher risk groups very precisely.
Harrison's gives some great examples of this kind of highly targeted screening. Let's walk through a few. How about screening for abdominal aortic aneurysm, AAA? That sounds serious.
It is serious. A ruptured AAA is often fatal, but routine screening isn't recommended for everyone. The USPSTF recommendation is incredibly specific.
Who hits the nod?
It's a one-time ultrasound screening recommended only for men aged 65 to 75 who have ever smoked.
Wow. Men, specific age range, and only if they have a history of smoking. Not women, not non-smokers.
Correct. Smoking is the dominant risk factor here. The risk of AAA in non-smoking men, or in women generally within that age group, is considered too low to justify the cost, the potential for anxiety from finding small, stable aneurysms, and the small risk of incidental findings on the ultrasound. It's highly targeted to maximize benefit.
That really narrows the field. Okay, what about lung cancer screening? Huge cause of cancer death, obviously linked to smoking, but the screening uses a CT scan, which has its own issues.
Right. Lung cancer screening uses low-dose computed tomography, LDCT. And again, the recommendation is very tightly defined, probably one of the most detailed examples of risk stratification.
So who qualifies for the LDCT scan?
It's recommended only for adults aged 50 to 80 years old, and they have to meet a very specific smoking history criterion. They need to have at least a 20-pack year smoking history, and they must either be currently smoking or have quit within the past 15 years.
Okay, let's unpack that. 20-pack years.
Yeah.
How is that calculated, and why that number?
A pack year is smoking 1 pack of cigarettes per day for 1 year. So 20 pack years could be 1 pack a day for 20 years or 2 packs a day for 10 years and so on. It's a measure of cumulative exposure. That 20 pack year threshold was based on the major clinical trials. It identifies a group with a high enough baseline risk of lung cancer that the demonstrated benefit of screening about a 20% reduction in lung cancer mortality outweighs the downsides.
Then the downsides are?
Radiation exposure from the CT scans, the cost, and again, a very high rate of incidental findings, little nodules or spots in the lungs that are mostly benign but require expensive and anxiety-provoking follow-up. The 20-pack year history ensures the benefit is likely to be worth those risks.
And why the 15-year cutoff if you've quit?
Because the risk of lung cancer drops significantly and continues to drop the longer someone has been smoke-free. The evidence suggests that after about 15 years of quitting, the risk profile starts to approach that of a never smoker, and the benefit of continued annual screening likely no longer outweighs the harms and costs. So the screening is effectively sunsetted for long-term quitters.
Fascinating. Very dynamic. Okay, one more common one. Diabetes. Huge public health issue. Are we screening everyone for that?
Surprisingly, no. Not the general population without specific risks. The guidelines generally recommend screening for type 2 diabetes using tests like fasting blood glucose or hemoglobin A1C, primarily in adults who are overweight or obese or who have hypertension.
So targeting people who already have known metabolic risk factors.
Exactly. People who fit the profile for metabolic syndrome or prediabetes. Screening this higher risk group increases the likelihood of catching diabetes early, when interventions like lifestyle changes or medication can be most effective in preventing complications. Again, it's about maximizing the yield and cost effectiveness, not universal screening.
Beyond these specific conditions or lifestyle factors, Harrison's also mentions the power of family history. How does knowing your family's medical past push you into a higher risk screening category?
Family history is a potent risk stratifier, especially for certain cancers with a known genetic component. The classic example used is colorectal cancer.
What's the rule there?
The general rule of thumb, which is widely adopted in guidelines, is this. If you have a first-degree relative, that means a parent, a sibling, or a child who is diagnosed with colorectal cancer, you should start your own screening 10 years earlier than the age at which your youngest affected relative was diagnosed.
10 years earlier. So if my dad got colon cancer at age 45,
You should start your screening at age 35.
wow, that could be 15 years before the general population recommendation, which is typically around age 45 or 50 now.
Absolutely. It's a significant shift, but it's based on the understanding that shared genetics and potentially shared environmental factors put you at substantially higher risk. Starting screening much earlier in these families is highly effective and clearly justified.
It really underscores that prevention is becoming less about one-size-fits-all mandates and much more about personalized risk assessment.
Completely. And that's where Harrison's hints at the future, too, mentioning things like omic, data genomics, proteomics, and advanced imaging. The idea is that as we get better at calculating individual risk using these sophisticated tools.
Like polygenic risk scores, maybe?
Well,
Combining lots of small genetic variants?
exactly. As those tools become more accurate and accessible, we might be able to pinpoint risk so precisely that broad population-based screening becomes obsolete. We might shift entirely to highly targeted prevention only for those identified as being at the very highest risk. It's a fascinating potential future.
Okay, so we've stratified risk, we've identified the target group. But what happens when, even for that specific group, the evidence is still fuzzy? When the benefits and harms are so closely balanced or depend heavily on individual factors that there's no single right answer?
That's where the patient has to come in, I assume.
Precisely. This is the domain of shared decision-making, or SPM. It becomes absolutely essential, really mandated, when the benefit-to-harm ratio is uncertain for that individual patient sitting in front of you. SDM means the clinician's role shifts. You're no longer just giving a recommendation, you're acting as an expert guide. You lay out the options, the evidence, including the uncertainties, the potential benefits, the potential harms. And then the patient's own values, their tolerance for risk, their life priorities, have to drive the final choice.
Exactly. It's their life, their quality of life on the line. Let's look at the two classic examples Harrison's uses where SDM is non-negotiable.
I'm guessing prostate cancer screening is one.
Absolutely. Prostate cancer screening with PSA is the quintessential example. We already talked about the huge uncertainty, the high rates of overdiagnosis, the fact that many prostate cancers are indolent, the competing causes of death in older men. The core issue is that the potential benefit of treatment preventing death from prostate cancer is often small, uncertain, and might only occur many years down the road. But the potential harms of treatment incontinence or erectile dysfunction are immediate, definite, and can be permanent.
That's a brutal trade-off.
Yeah.
Risk definite harm now for an uncertain, distant benefit.
It is. And different men will weigh that trade-off very differently. One man might find the idea of having an untreated cancer, even a slow-growing one, completely intolerable. He might accept the high risk of side effects to get rid of it. Another man might prioritize preserving his current quality of life, his sexual function, above all else. He might choose active surveillance or watchful waiting, accepting the small risk the cancer might progress to avoid the treatment harms.
And there's no right or wrong answer there. It's purely down to personal values.
Exactly. It depends on fear, anxiety, priorities in later life, personal relationships, things a guideline can't dictate. So the only appropriate recommendation is not for screening itself, but for an individualized discussion about screening leading to a shared decision.
Okay. What's the second major case study for SDM mentioned in Harrison's?
The other great example is choosing among the different colorectal cancer screening techniques. This one is slightly different. Here, the issue isn't so much uncertainty about whether screening is beneficial, it clearly is, but uncertainty about which method is best for a given individual.
Because there are several proven options, right?
Yes, and they have very different profiles in terms of invasiveness, preparation, frequency, and, importantly, effectiveness. Harrison's mentions the main categories. First, you have the stool-based tests. like the older fecal occult blood test, FOBT, or the newer fecal immunochemical tests, FIT, and stool DNA tests. These are non-invasive, done at home, usually annually. They're shown to reduce colon cancer deaths by, say, 15 to 30%.
Okay. Easy, but maybe less effective.
Lower efficacy per test, yes. Then there's flexible sigmoidoscopy. This involves inserting a scope, but only into the lower part of the colon. Requires some bowel prep, usually done every 5 years, sometimes combined with stool tests. It reduces deaths by maybe 40 to 60%.
Better efficacy, but more invasive, more prep.
Correct. And third, there's colonoscopy. Full scope, visualizes the entire colon, allows removal of polyps right then and there. It requires full bowel prep and usually sedation, typically done every 10 years if normal. It seems to offer the greatest potential risk reduction, maybe 50 to 70% under ideal conditions.
So wait, if colonoscopy reduces risk by 50–70% and stool tests only by 15–30%, why isn't colonoscopy the only recommendation? Why is there even a choice? Surely maximizing the risk reduction is the goal.
That's the million-dollar question, and the answer is fascinating. It comes down to two things: cost-effectiveness modeling and adherence. While colonoscopy has the highest efficacy per procedure, when health economists model these strategies over a lifetime, considering the required frequencies.
Like annual stool tests versus a colonoscopy every 10 years.
Exactly. And crucially, factoring in how likely people are to actually do the recommended test on schedule. The model suggests that all three approaches, annual high-sensitivity stool testing, sigmoidoscopy every 5–10 years, maybe with stool tests, and colonoscopy every 10 years, achieve remarkably similar outcomes in terms of lives saved and QALYs gained.
Really, similar outcomes despite the different efficacies.
Yes, and they also tend to fall within a similar, very cost-effective range. Harrison's mentions $10,000 to $25,000 per life year saved in some models, which is excellent value. The key is compliance.
So a test someone actually does is better than a theoretically superior test they avoid.
Precisely. Some people will diligently do a stool test every year, but will put off scheduling a colonoscopy indefinitely because they dread the prep or the procedure. Others prefer the one and done for 10 years aspect of colonoscopy, even with the hassle. Because adherence is so critical to long-term success and different people have different preferences and tolerances, offering a choice is actually the most effective population strategy. The best test is the one the patient will actually complete reliably over time.
So the shared decision-making here is about finding the method that fits the patient's life and preferences, ensuring they stick with a proven screening strategy.
Exactly. It's about partnership to ensure prevention actually happens.
We spent a lot of time talking about tests, procedures, technology, but Harrison still has a really powerful point. The biggest wins in prevention often don't come from a screening test at all. Where does the text say the vast majority of preventable deaths in developed nations actually stem from?
It points squarely at four fundamental areas of behavior: tobacco use, alcohol use, diet, and physical inactivity.
The big lifestyle factors.
Absolutely. These are the primary drivers of the major chronic killers: heart disease, many cancers, stroke, type 2 diabetes. The cumulative burden of disease and premature death caused by these behaviors absolutely dwarfs the impact of many of the screening interventions we've been discussing.
And Harrison's is incredibly direct about identifying the #1 priority within these behaviors, isn't it?
Unequivocal. It states that helping patients quit smoking is the single greatest preventive healthcare measure a provider can undertake, period.
The single greatest measure. Why is the impact so disproportionately large compared to, say, screening?
It's about the magnitude of benefit. Think about the gain in life expectancy. A middle-aged smoker, maybe 35 or 40, who successfully quits smoking might gain, on average, 3, 4, even 5 years of life.
Years. Not weeks or months.
Years. Compare that to many screening tests. Even highly effective ones like mammography or pap smears, when averaged across the population, might shift the average age of death by weeks or months. Finding years of life gained from a single intervention like smoking cessation is just unparalleled in preventive medicine. That's why tackling behavior has to be front and center.
Okay, if the payoff is so massive, especially for smoking cessation, why are these behavioral issues, quitting smoking, losing weight, cutting back on drinking, often described as being so difficult? Harrison uses the term recalcitrant to intervention. Why are they so tough to change?
Because they're not simple choices. They're deeply ingrained behaviors, often linked to addiction, habit, stress, mental health, social environments, economic pressures. It's incredibly complex.
It's not just about telling someone you should stop smoking.
Right. That rarely works for someone with a long-standing habit or addiction. These behaviors often serve a purpose for the individual, even if harmful. Coping with stress, social connection, managing withdrawal. Change requires overcoming physical dependence, rewiring habits, developing new coping skills. And it's often not a one-time fix. Behavior change takes sustained effort, often involves setbacks or relapses, which makes it really challenging for both the patient and the clinician. It requires patience, persistence, and often a multi-pronged approach.
Like using medications plus counseling.
Exactly. Pharmacotherapy for nicotine addiction, for example, combined with repeated counseling, motivational interviewing, support groups, addressing underlying depression or anxiety. It's intensive work, hard work, but given the potential payoff, it's work we absolutely have to prioritize.
And despite these challenges, the evidence does support the idea that clinicians can make a difference with counseling, right? What are the key counseling topics the USPSTF strongly recommends, based on the evidence summarized in Harrison's?
Yes, the evidence is clear that even brief interventions by healthcare providers can significantly influence patient behavior. The USPSTF has identified several high-priority counseling topics where the evidence for clinician impact is strongest. These include things like screening and counseling for alcohol and drug misuse, often using structured approaches like brief intervention or motivational interviewing. They strongly recommend genetic counseling for women identified as high risk for hereditary cancer syndromes like BRCA12 mutations. Counseling on nutrition and diet, particularly for patients with related risk factors like obesity or high cholesterol, is key. Advising on safe sexual practices to prevent sexually transmitted infections, STIs, is another core recommendation. And of course, comprehensive counseling and support for tobacco cessation.
What about other common sense things, like telling people to exercise or wear seatbelts? Are those formally recommended for counseling too?
It's a slightly different category. Harrison's notes that counseling on things like physical activity or injury prevention, wear your seatbelt, wear a helmet if you ride a motorcycle, is routine in primary care. The benefits are often self-evident. While the USPSTF might not have a specific grade A recommendation for the counseling session itself about seatbelts, because it's hard to design a trial for that, the importance of addressing these leading causes of injury and mortality means they remain standard, expected practice. The focus of the formal, evidence-based counseling recommendations tends to be on those complex, chronic behavioral issues where structured intervention has proven most impactful. #tag6, practical implementation, and sunsetting screening. So we've figured out what to recommend, we've weighed the benefits and harms, maybe even had that shared decision-making conversation. Now comes a really pragmatic challenge. How do we actually deliver these preventive services effectively and reliably across a whole population, especially in busy clinics?
Yeah, it seems impossible for one doctor or nurse to remember every single guideline for every single patient based on all those different risk factors and ages. The system has to help, right?
Absolutely. Relying on individual clinician memory is just not a sustainable or reliable strategy. We heavily depend on system-level supports. And the most important one today is probably the electronic health record, the EHR.
How does the EHR help beyond just storing notes?
A well-configured EHR acts as an active partner in prevention. It should have built-in clinical decision support, basically, reminder systems, based on the patient's age, sex, diagnoses, smoking history, family history. The EHR should automatically flag when they're due for specific preventative services. A pop-up might say, patient due for colorectal cancer screening, or recommend zoster vaccine.
So it prompts the clinician at the point of care.
Exactly. It automates the tracking and minimizes the chance that something gets missed simply because things are busy. These reminders significantly improve adherence rates for recommended screenings and vaccinations. Another key piece is patient engagement through technology. Giving patients secure access to their own health records, often via patient portals, can also help.
How so?
Many portals now include personalized reminders for patients about their own upcoming or overdue preventative care. It empowers them and shares the responsibility for staying on track.
Okay, so EHR reminders and patient portals help with tracking. What about actually getting things done efficiently in the clinic, like vaccinations?
That's where standing orders are incredibly valuable, especially for routine, highly effective services like immunizations.
What's a standing order?
It's a pre-approved protocol that allows designated staff, often nurses or medical assistants, to administer certain treatments or services, like vaccines, without needing a specific physician order for each individual patient, as long as the patient meets the criteria defined in the protocol.
So if a patient comes in for anything, and the nurse sees they're due for their flu shot based on the EHR reminder,
the standing order allows the nurse to just give the flu shot right then and there without having to wait for the physician to sign off specifically. It removes a major bottleneck, makes the process much more efficient, and significantly boosts vaccination rates, particularly for things like influenza and pneumococcal vaccines.
Makes sense streamlining the workflow. Now, we've talked a lot about starting screening, but Harrison's also emphasizes the importance of knowing when to stop. Why is sunsetting screening services just as crucial?
This is a really important, sometimes overlooked aspect of prevention. The rationale for stopping is based on a couple of key biological and statistical realities. First, as we touched on, for many screening tests aimed at preventing death from a disease, like cancer, the benefit doesn't actually show up immediately after the test. There's a lag time. It often takes 5, 10, or even more years of follow-up after early detection for that benefit, the reduction in mortality, to become statistically apparent.
So detecting something early doesn't instantly save a life. It just starts the clock sooner. The survival advantage takes years to manifest.
Exactly. It's often called lead time. So if a patient's overall life expectancy, due to age or other serious health problems, is shorter than that required lead time.
Then the screening test can't possibly benefit them in terms of living longer.
Precisely. If an 88-year-old patient has advanced heart failure and maybe only a couple of years left to live, starting screening colonoscopies, where the mortality benefit might take 10+ years to accrue, is medically futile. It offers only risk from the procedure and cost, with no realistic chance of extending their life.
So there were general age cutoffs.
Generally, yes. The evidence base supporting continued screening gets much weaker, or disappears entirely for most conditions beyond age 75 or 80. The potential harms start to outweigh the shrinking potential benefits for many tests. Critically, for patients who have already developed advanced life-limiting illnesses, regardless of their age, the entire focus of care needs to shift. You move away from routine preventive screening and towards maximizing quality of life, managing symptoms, providing comfort. Palliative care principles become much more relevant than screening for new problems.
It really highlights how prevention isn't static. It has to adapt constantly to the patient's evolving health status and prognosis. Harrison's provides that nice summary linking prevention strategies to age-specific risks.
Yes, that's a great way to see how the priorities shift across the lifespan, targeting the most likely threats at each stage.
Can you walk us through those key transitions? What's the focus for, say, young people?
Okay, for adolescents and young adults, maybe ages 15 to 24, the biggest threats aren't chronic diseases yet. The leading causes of death are external. Accidents, especially car crashes, homicide, and suicide. So prevention is overwhelmingly focused on behavior and safety counseling. Seatbelt use, substance abuse, alcohol, drugs, mental health screening, depression, suicide risk, safe driving, maybe gun safety, and of course, STI screening and ensuring vaccinations are up to date, like HPV.
Very behavior and trauma focused. What happens in midlife? Maybe ages 45 to 64.
Here, the picture changes dramatically. Internal diseases surge, malignancy and heart disease become the top risks, so the focus shifts accordingly. This is prime time for starting colorectal cancer screening. Discussions about prostate cancer screening using STM begin. Breast cancer screening discussions intensify. We add the zoster vaccine to prevent shingles. And there's a huge emphasis on identifying and aggressively managing all cardiovascular risk factors, checking cholesterol, blood pressure, screening for diabetes if indicated. For those high-risk smokers, lung cancer screening starts in this window too.
A big shift towards internal medicine screening. And then for older adults, ages 65 and up.
The major players continue to be heart disease, cancer, and now also cerebrovascular disease, stroke. But new risks related to aging and frailty emerge. So we continue appropriate cancer screenings like colon and maybe lung, depending on age and history. We add that specific AAA screening for men who smoked. Osteoporosis screening becomes important, especially for women, to prevent fractures, and crucially, preventing falls becomes a major goal. So interventions like exercise programs focused on balance and strength are recommended. Plus, vaccinations become even more critical. Annual high-dose flu shots, routine pneumococcal vaccines, keeping up with zoster boosters. The focus is increasingly on maintaining function and preventing acute events in the context of existing chronic conditions. It's a dynamic adaptation across the entire lifespan. Hashtag recent updates evidence.
Okay, so pulling this all together, the framework Harrison's lays out the economics, the USPSTF's role, risk stratification, shared decision-making, counseling, implementation. It really explains the ongoing debates we still see in medicine today, doesn't it? Let's connect those core principles back to some of the specific controversies.
Absolutely. The fundamental tension between maximizing benefit and minimizing harm, especially overdiagnosis, is alive and well. Take the mammography debate for women in their 40s. Harrison's highlighted the controversy, and, well, it's still controversial. Recent guidelines still reflect that difficult balance. Some groups push for earlier screening, emphasizing the potential life saved, while others, like the USPSTF, remain more cautious, often a C grade, pointing to the high rates of false positives in this age group and that persistent problem of overdiagnosis.
That 15–40% estimate of overdiagnosis is hard to ignore.
It really is, and it forces that difficult conversation. How many women are we willing to potentially overtreat to find one aggressive cancer earlier? Different organizations draw that line in slightly different places, leading to the ongoing guideline variations. The core issue identified in Harrison's remains the central challenge.
And the prostate paradox seems to have largely settled into that shared decision-making model, as Harrison suggested it should.
That's largely true. The concerns about overdiagnosis, again, that 15.7% figure cited, and the significant quality of life impacts of treatment have led most major guideline bodies away from recommending routine PSA screening for all men. The standard of care now is shared decision-making. The evidence just isn't strong enough to support a blanket mandate. The clinician's job is to present the complex trade-offs, the uncertain benefit versus the certain risks, and help the patient make a choice aligned with his own values. That's a direct consequence of the benefit arm calculation being so unfavorable at a population level.
And what about colorectal cancer screening? Harrison's seemed to validate using multiple different methods based on patient preference. As that held up?
Yes, completely. The principle that adherence is key and that multiple strategies can be similarly effective and cost-effective if done correctly has only been reinforced. While we have ongoing research comparing methods head-to-head, the real-world modeling continues to support offering a choice. Whether it's a high-quality annual stool test, sigmoidoscopy, or colonoscopy at the appropriate intervals, the evidence suggests they all significantly reduce mortality. So, the takeaway remains. Find the method the patient is most likely to actually do and support them in doing it. Patient preference isn't just a nice to have, it's integral to the success of the screening program, just as Harrison's implied. #tag summary.
This has been a really thorough deep dive into the often complex, sometimes counterintuitive world of preventative medicine decision-making. Let's try to boil down the most critical takeaways for you, the listener, based on our discussion of the Harrison's text.
Okay, first point. Remember that prevention is different. Because we're intervening on healthy people, the evidence bar for benefit has to be incredibly high. And costs matter, not just test costs, but downstream costs from false positives and incidentalomas, all weighed against those quality-adjusted life-year thresholds, typically $50K to $100 in the U.S.
Second, the USPSTF is the key independent body weighing this evidence, using grades A through I. But consensus breaks down, especially for things like breast screening in the 40s and prostate screening, largely because of the significant risk of overdiagnosis treating cancers that might never have caused harm.
Third takeaway. Risk stratification is crucial for efficiency. We don't screen everyone for everything. We use factors like age, smoking history like for AAA and lung cancer, family history like for early colorectal cancer screening, and other conditions like obesity, hypertension for diabetes screening to target interventions to those most likely to benefit.
Fourth, when the evidence remains uncertain even after stratification, or when adherence depends heavily on the patient, shared decision-making becomes essential. Think about choosing between colon cancer screening tests based on preference, or the intensely personal decision about PSA screening for prostate cancer.
Fifth, don't forget the basics. Despite all the focus on high-tech screening, counseling on behavior change, especially helping patients quit tobacco, offers the single biggest impact on preventable death and yields far more life years gained on average than most screening tests. Addressing alcohol, diet, and exercise is also paramount.
And finally, sixth, effective prevention requires systems. EHR reminders, patient portals, and standing orders help ensure recommendations are actually followed. And just as important as starting screening is knowing when to stop sunsetting tests when a patient's limited life expectancy means the benefit can no longer realistically accrue.
So maybe a final thought for you to mull over, something that builds on this idea of refining risk. We talked about risk stratification getting better and better, maybe using genomics or complex imaging data in the future. If we get really good at identifying, say, the top 1% or 0.1% highest risk individuals for a particular disease, would that essentially eliminate the need for broader population-based screening altogether? Could all prevention become hyper-personalized, targeted only at those few truly high-risk outliers? And if so, what would that mean for equity? How would we ensure everyone, not just those who can access sophisticated risk prediction, still benefits from preventive care?
That's a fascinating question about the future direction of all this.
Yeah.
Definitely something to think about. Thank you for joining us on this deep dive. Until next time.